Thank you to everyone for attending today's webinar. I'd like to take a moment to thank the funders of Cochrane Canada, without whom these webinars would not be possible. Thank you to CIHR for their support. I'd also like to thank PAHO for providing the software for our webinars, and a special thank you to Luis Gabriel Cuervo, who produces videos of our webinars. Without further ado, I'd like to introduce today's session on non-randomized studies and EPOC reviews. We'll be hearing from Alain Mayhew. Alain Mayhew is the Managing Editor for the Cochrane Effective Practice and Organization of Care Group based at the Ottawa Hospital Research Institute. He graduated from the physiotherapy program at University of Toronto in 1981 and completed a master's degree in epidemiology in 1999. He has been involved with EPOC for the past 8 years and has a particular interest in the inclusion of non-randomized studies in systematic reviews. Al, please go ahead.
Thank you, Catherine. Really a pleasure to be here today, and I hope that I can share with you some different perspectives or different knowledge around the inclusion of non-randomized studies in systematic reviews, and with particular emphasis on EPOC. But maybe I will just follow Catherine's lead and ask for happy faces or indications if there's a problem with the volume. So make sure that you can all hear me well, and if some of you could give me an indication on that, that would be helpful. All right. Okay, good. All right. That's great. I'd like to also thank those of you who are joining us from places where time zones aren't convenient, because I really appreciate you taking time out of your busy lives, even for those of you who are doing it from work, but also for those of you who are doing it from difficult times. This presentation is actually, sorry, there's my title slide. Let's start with that. So as Catherine mentioned, we are supported by Cochrane Canada Live, and I'd also like to thank the funders who are supporting this activity. This presentation is out of a paper that is going to be published shortly in the Journal of Clinical Epidemiology, and I've just listed the reference there at the bottom on that slide. And I'd like to acknowledge my co-authors, who are the first 4 people listed there: Claire Glanton, Simon Lewin-Inger Schiel, and Jan Odgaard Jensen, who are very helpful in the publication of this paper. It's a project we've been working at for a while and been very interested in doing, and we're really glad that it will be published. Julie Wu was also really helpful. Julie's a research assistant working with me, and she has been really helpful in getting these slides together. All right, so on to the next slide. So I'm going to turn over to Catherine, who's going to help me set up this poll for this next slide, okay, because we want to test the system. So the question is, why would I include this picture in the presentation? And there are 3 options. One is we're testing the poll feature. Second option, symbolic of the first day of spring and sunshine outside, even though it's not. It's actually gray today, and even though we still have over 10 centimeters of snow. Or the third option, it's a visual indicator of the importance of being clear and transparent when writing a systematic review. So I welcome your choices.
As a reminder, please use the little letter A at the top of the participants window to send your response.
Okay, giving you a couple more seconds here. It's actually a test to see who the jokers are in the group, you know, and see who responds.
Okay, thank you everyone for sending your responses. Al, it looks like most people have selected C.
It does, or none. Yeah, which is fine. And I think if those of you who heard me present before or know it's a real important issue with Cochrane and all systematic reviews, that we really do push for transparency. And what always comes up in these things is that there's more than one way to skin a fish. There's more than one way to evaluate or to approach a systematic review about any given question. But what's really critically, absolutely important is that you're clear so that the readers understand what you did. There's going to be times when you don't agree with what an author did in a particular review, but you want to at least be able to understand it so that you can make a reasonable argument against it. So just really, I jump up and down about this whenever I present. It's just a really important issue. You just need to be clear and transparent so that everybody can understand what it is you're trying to do. Okay, next slide. So, starting with a little bit of background, historically, most Cochrane groups have only included randomized trials or randomized controlled studies, okay, randomized controlled trials, because that has been the gold standard in most of, in scientific research of interventions, and they've been what's been recommended. However, the Cochrane Handbook, most recent version, has suggested we can include non-randomized studies, particularly for harms and long-term outcomes. Basically, a lot of randomized trials are done on short terms, and they end too soon to be able to do a non-randomized, to be able to evaluate for outcomes, whereas non-randomized studies tend to go on for longer periods, which is, you know, advantageous for finding harms and outcomes. As you probably are aware, there are 52 review groups within Cochrane. I work for one, which is known as EPOC, which I'll give you a bit more information on that. These four, there's roughly, I think there's 15 or so out of Cochrane that will consider non-randomized studies. These four here will actually consider non-randomized studies for short-term effects as well. So not just looking at harms and adverse events, but looking at all sorts of short-term effects. EPOC is one, the Consumers and Communication Group, the Injuries Group, and the Public Health Group. We do ask for some sort of rationalization why authors would consider to include a non-randomized study, but it is a little more open to do that. So EPOC, the group that I've been affiliated with, as Catherine mentioned, for about 8 years, stands for the Effective Practice and Organization of Care Group. We're one of the Cochrane review groups. Our focus, just to give you a bit of a perspective, is to look at systematic reviews of interventions to improve professional practice, healthcare systems, and delivery of healthcare. We don't have a specific clinical focus, all right? I like to usually give people examples of two of our reviews. One is the effect of printed education materials. So it's the effect of articles and flyers and publications that people might read and whether they actually change behavior. So we don't look at just one behavior like just prescribing or just surgery. We would look at the effect of these types of interventions on any kind of behavior. Similar, we have another review on on-screen computer reminders. And if you just imagine your family doc is seeing you and they're seeing any patient and he's typing the information as you go, and this pop-up on a screen says, did you check Mr. X's feet because he's diabetic? So it's just a reminder. Again, we wouldn't focus our review specifically on any one clinical practice. It could be prescribing, it could be counseling, it could be ordering a test. But the intervention is something that affects that. So a lot of times we're looking at outcomes of professional care. We also will consider reviews of organizational and regulatory interventions and financial ones too. We have reviews on co-payment systems and financial interventions that might change how someone's practicing. We are based in Ottawa, which is where our main editorial base is, right down the hall from the Canadian Cochrane Centre. And we're fortunate enough to have 4 different satellites around the world, one in Melbourne, Australia, Oslo, Norway, Oxford in the UK, and in Paris, France. So we are able to provide some local support for a lot of international researchers. We also have, we have 16 core and specialist editors. Our specialist editors are economic and statistical. And we have roughly 1,000 authors with around 100 reviews and 45 protocols. Okay, I see there's a question there. I'm actually have a spot about halfway through my presentation where I'm going to take some questions. So I know there's one there. Thanks for submitting it, and I will bring it back. I will bring it up a little halfway if that's okay. So within EPOC, we will consider multiple designs of multiple study designs for our reviews. We obviously consider randomized controlled trials, and we often see cluster trials. As you can imagine, a lot of professional interventions or even financial or organizational interventions might be implemented at a hospital level. You know, one hospital might get the intervention and maybe randomized to the intervention group, and another hospital might not. So That's one of the issues. That's one of the types of trials we'll consider. There's some analysis issues that are really important that are way more than I hope to go into, than I'm able to go into today. But cluster trials are one of the options we'll consider. We'll also consider some non-randomized controlled trials, ones where, for example, one type we'll consider is any experimental study where there isn't a perfect random allocation that occurs. All right, you know, people are randomizing by day seen or by health insurance number, something that's not random, or an alternate random allocation. We would consider those designs depending on the review. We'll also consider what we call a controlled before and after study. Okay, so this is a two-arm trial where there were measurements done before the intervention and after, and we asked for a minimum of 2 groups to receive the intervention and 2 groups to receive the 2 groups to be in the control. So if you're dealing with hospitals, you would have a minimum of 4 hospitals, 2 where the intervention occurs and 2 where it doesn't. We just found there were a lot of studies and there was a lot of inherent bias with these because with only 2 groups we weren't able to measure that. So we've gone to a 4-group system, but this is our criteria for that. So I'm going to bring this point up again, but I'll just allude to it now. It's really important if you're including non-randomized studies in a review that you define what you mean by a controlled before and after study, so that somebody reading it can say, okay, if that's an EPOC and it's a review, it has to meet these following criteria. And we also will include interrupted time series. At a minimum, our interrupted time series has to have 3 data points before the intervention occurs and 3 data points after. Okay, that's at a very minimum. So just to give you an example, graphically here, the intervention for this particular study occurred in May 2011, and there would be at least 3 data points, January, February, March, and April before, and then another 3 data points after. So again, we will consider these designs within our reviews. You'll see a lot of organizational type of interventions will use this sort of design. Say we're going to implement a new referral system, and so we'll evaluate the current referral system and see what happens for 3 months first, and then after the intervention we can evaluate for 3 months after. And again, the main criteria is there's at least 3 data points before the intervention occurs and another 3 data points after. Ideally, in a perfect world, we'd hope the ITS designs look like this, and when we're analyzing them, more often than not, they look like this. And this is actually, this study is actually looking at warnings on alcohol labels for prenatal drinking, and it just testing to see how much the subjects were actually consuming alcohol, depending on whether it was measured before the intervention started, of putting the warnings on the alcohol versus after. So I think you can appreciate these are really messy to analyze, and they're very challenging. The advantage to using 3 or more data points is you get some sense of the seasonal variation and be able to avoid that. And the other thing is they have to be analyzed. It's a very complicated method of analysis. You can't just take the average before and average after, because it doesn't take into account the step or the slope changes, which again are more detailed than I'm able to go into today. So, time for a second poll, and I'm going to throw this out to you and say, what is the best reason, in your opinion, for including a non-randomized study in a systematic review? So we have 5 options this time. A, there's no randomized trials addressing the question. B, it's impossible to do an RCT for that particular question. C, a non-randomized study could provide more information. D, more non-randomized study data is available. Or E, if you don't include non-randomized studies, you will miss a high-profile non-randomized study which was done, which in your opinion should be included in the review. So, best answer.
All right, I see a lot of responses coming through. We'll just give it 1 more second. You can send your answers using the little drop-down letter A in the participants window. Okay, and the most popular answer was B.
Okay. Okay, great. Okay, we're going to explore them all one by one because that's what I just wanted to get a perspective on this. I see some of you have actually, yeah, it's interesting. So I think the best answer is probably B as well, but let's just sort of explore all the options because this is commonly an issue we have to deal with, that people are unsure about including non-randomized studies or their rationale for doing so. So the first option was you want to include non-randomized studies because there are no RCTs addressing the question. Really, this unfortunately raises more questions, and it's a real challenging one. And the question is an empty review where the authors only look for RCTs better than a review of X, of 17, of 4 studies of non-randomized trials? So are you better having no evidence, no RCT evidence, and being able to say we really don't know if intervention X works, or are you better having some non-randomized study evidence which has its limitations? You kind of get into a bit of a discussion here between your purists versus your policymakers, okay? Because your purists are going to say, well, no, you really need your RCTs. They're better quality. There's generally less risk of bias, and generally they're easier to find and do. But oftentimes the policymakers don't have time to wait for the RCTs to be done, and they need an answer right away. And it's just one of those struggles people often have. Some people think we shouldn't be accepting reviews because they're empty, or they will potentially be empty, and they should be, because it doesn't really say anything. It's really one of those discussion points that we haven't got a firm answer on yet. Second option was, is it impossible to do an RCT for that question? And everybody always likes to use the parachute example, that you can't randomize a study on whether parachutes work or not, because it's just not feasible and probably not ethical. But we always seem to get into, again, longer discussions about when is it really impossible to do an RCT for a question, okay? Some people will argue that standard practice should not be randomized in a study against no treatment control because it's unethical. Well, if we're doing a treatment that doesn't work, that's arguably unethical as well, okay? I mean, I think we can be pretty sure about the parachutes, but a lot of times it's really difficult to get an answer on this. This is one of the studies people often cite when they're talking about including non-randomized studies. A Cochrane review looking at the effect of pool fencing on preventing drowning of children. Now again, they mentioned their eligible study design as being studies with a comparison group and also with objective data. So that's all they say. They didn't say they were going to include cohort studies or anything else. They said these are the eligible study designs. They had to have a minimum of a comparison group and a minimum of objective data. In the results, they actually found 3 case-control studies which met their criteria. Obviously, they didn't find any randomized controlled trials. And the results, 2 main conclusions. One is pool fencing appears to reduce the risk of drowning. And secondly, fencing, which isolates the pool from the house, is much more effective than available access to the pool through the house. Okay? Really interesting review, but also interesting from the methodological point of view that they weren't able to include any non-randomized trials, and so they, set the criteria up for what their non-randomized studies are. And it's a good example of where it's not feasible to do a randomized trial because you've got to get any participants who would agree to that. I think this answers Chris's question that he's posting. Non-randomized studies could provide more information, particularly in terms of long-term outcomes such as harms and adverse events. I mean, you're absolutely right, Chris. I think there is risk of bias and there is allocation issues and there are problems with that. But the fact is, if you actually go back and look at the evidence, most randomized controlled trials are shorter than a lot of non-randomized studies. So if you actually want to see if over the next 10 years aspirin leads to stomach ulcers on a long-term basis, you actually have databases that you can use and you can follow, and studies that go on for long periods of time that actually can measure these adverse outcomes. So that's one place where non-randomized studies can be really helpful. I agree if you're looking at a short-term outcome, you're better off with an RCT. It's better quality evidence, it's got less risk of bias, and it's probably more likely to give you the answers that you want, but we're just thinking in terms of long-term outcomes. Does that help?
Okay, that looks like you've answered this question now. Thank you.
Okay, great. Next slide. This is one I've got into, again, more discussions with people about the question of whether is it better to include non-randomized studies to be able to get more data. Okay, and there's two real big issues here. One is, what's the magic number of studies to include? When do you decide you have enough RCTs? And you shouldn't be driving the research question on the amount of studies that are done. Okay, you can make that argument for 0. You can't really make it for anything else, in my opinion, because you can't really say what is the magic number of enough or not enough RCTs. So that should be including non-randomized studies. And also, any decision to include non-randomized studies should be made a priori. It should be written in your protocol, probably preferable when you first suggest your title, because you have to develop your search strategy, develop your methods based on those decisions, and you should be making this decision a priori. Secondly, I'd just like to point out, AmStar is one quality assessment tool we often use for systematic reviews in some of our projects, and it does not in any way rate a review with more studies as higher quality than one with less. So it does not, according to this scale, the quality of a systematic review does not depend on the number of studies. Okay, so therefore this is not a rationale to include non-randomized studies that you're going to find more papers. Finally, option E, you might miss including a high-profile non-randomized study, which should be included in your review if you only include RCTs. Well, I would make the same argument for randomized controlled trials. The fact that it's high-profile is not a reason to include it. Any high-profile RCT would only be included. You would only include it only if all the inclusion criteria were met. Right? You're not going to include an RCT just because it's high-profile and was published in a high-impact journal. So the same rules should apply for decisions to include non-randomized studies. As many of you are probably aware, within Cochrane reviews, there are oftentimes authors in their discussion will go into some of these issues and say, we found the following 2 studies that were ineligible because of A, B, and C. However, they did explore the following outcomes that weren't discussed in any of the other reviews. So it might be a good example to be able to use that, to be able to say, you might be able to do that within your discussion, to say, you know, there's a really high-profile non-randomized study that has a very big sample, but unfortunately didn't meet our eligibility criteria, but this is what it met, and this is what it found, and this is how it compares to the rest of the studies in the review. So again, I'd just like to throw out that there's a couple of different options there, but to include a study just because it's high profile is not a good reason. I touched on this earlier. I'm going to come back to it again. Specifically in the Cochrane Handbook, it says, when defining your eligibility criteria for non-randomized studies, use specific features of study design. For example, which parts of the study were prospectively designed, rather than labels. And I've just repasted the information about the Pool Fences review. Their criteria did not say they would include 2-group before-after studies. They said the designs had to have a comparison group and had to have objective data. So it's very clear, and you can tell which studies were eligible. This, I would say, is a relatively common non-randomized study design. You have 2 groups. There is no randomization occurs. You have 1 group as your intervention, your 2nd group as your control. You have pre and post values pre-measured at time 1, then your intervention occurs, and then post at time 2. And you have an intervention occurring at the same time. The challenge is what you call that. And I would make an argument you could call it any one of these 7 different titles. So subsequently searching for these studies becomes really challenging, because it's quite possible what I would call it is not necessarily what the 44 people in this room would call it. Okay, so everybody's going to give it a little bit of variability, or might call it something else depending on what you've been trained to call it, depending on what your experience is, and depending on what you believe. So it becomes really hard to search for and find these studies because people call them by different names. So again, our recommendation within Cochrane is to say, these are the studies I want to include, and in order to be a two-group pre-post study, it has to have the following features. It doesn't eliminate your searching problem, but at least it identifies which studies you would choose to be eligible and not. So if you are going to include non-randomized studies in a review, first of all, make the decision a priori, just like you would for any other PICO component, at title or at the protocol stage at least. You're not going to make this decision based on the fact that you only found a small number of studies. You need to make the decision in advance. Secondly, you need to justify the decision. Come up with some reason or rationale as to why you might want to include non-randomized studies. Because we know because we don't think there's any, because it's not feasible to randomize in this particular case, whatever. But you need to have a rationale. And thirdly, when identifying what you mean by your non-randomized studies, make sure you use design features, not labels, or define your labels. As I said, we call it an interrupted time series, which has a minimum of 3 data points before the intervention and 3 data points after. So I'm going to pause here for a second and see if anybody wants to type in any questions. I'll give you like 30 seconds to a minute to do that, and I'll have a sip of my water so my voice doesn't totally go here. And just see if anybody wants to type anything in the chat group or any points they'd like me to re-clarify before we go on.
Okay, if anyone has any questions, please type them into the chat room. And I'd just like to let everyone know that after the presentation, we will be sending around the slides, as well as any additional resources that Alice has brought up during his presentation. It looks like we have a few people typing in, so we're just going to wait to see what their question is.
That was really great. Oh.
All right, so Becky is asking, in your pool fence example, what can we conclude at the end of the day based on 3 case control trials?
Good question, Becky. It's a good question. It seems to be we're concluding based on these results that the pool fences seem to work. I think I'm not aware. I don't know where this review is at, if it's been updated since it was last published. And you're right, there is limited evidence because it is only based on 3 studies. But I think the results were strong enough and consistent enough that the authors felt they could say that these pool fences work. Any community that I've lived in, I know that's the bylaw for pool fences, that you have to have it all the way around your house, and it has to be separate from your house in terms of the fence, in terms of an entrance, so it's separated from the house. But you're right, it's a very good question. Can we actually conclude that they actually work? Well, the evidence is consistent, and it seems to work, and it's biological plausibility, and those kinds of things. So I would feel comfortable saying, yeah, it appears to, but you're right, we can't say it for sure. Okay, Kristen, do you think it's sorry, my screen just changed. Do you think it's acceptable to decide a priori to include non-randomized studies, but when you get your lit search and find there's enough info in RCTs, and then choose to omit? To be honest, Kristen, I'm happier with that decision than the opposite. I would be more nervous about someone who says they're going to just include RCTs, then they don't find any, and then they decide to add our non-randomized studies. We have some updates in our EPOC review where they started, when they did the first version of a review, they looked for randomized and non-randomized studies. And then as time went on, they actually found, you know, people are starting to do RCTs in this area, and so they actually start co-opting the non-randomized studies. So we've seen that specifically happen in terms of updating reviews, which, as you all know, is one of the expectations within the Cochrane library. So that's the approach I would take. So like I said, I like that idea better than I do deciding to add non-randomized studies. Is there a specific validated search filter for non-randomized studies? We have search filters within EPOC that we use. To be totally honest, I'm not sure how. I assume they're validated, but I don't know to what level. If you were to send me an email about this after, I can speak to our trial search coordinator and go back to that. So we do have some search filters in EPOC looking for non-randomized studies, but I'm not sure how well validated they are. I'd have to check with our TSC. But if you send me an email after, I can check into that for you.
You can ignore the sample size. That was in reference to a previous comment.
Oh, okay, great. Chris, I have a question on diagnostic accuracy. We don't do reviews on diagnostic tests, unfortunately, Chris, because you think about the kind of interventions we look at, looking at interventions to change professional behavior. There really aren't diagnostic tests for those things because we would cut across all clinical conditions. So I can't answer this question for you. I'm really sorry, but I have to rack my brain to go back to a few years ago of knowledge. But anyway, then I would suggest you might want to talk to somebody in the diagnostic methods group. Again, if you send me an email, I can do an email introduction after and help you with that. But we don't do diagnostic reviews because they're just not in our scope. And Aaron, oh, thanks. Aaron just put the link up for the diagnostic test accuracy working group, and you can contact them through that link. But if you wanted a personal introduction, just send me a note and I'll have to do that. Aaron, what are you referring to?
When I'm asking about the bias out, what I'm wondering is if you've decided a priori to include non-randomized studies, but after you do your search, let's say that you find a substantial number of RCTs and some non-randomized studies, would it not be introducing bias at that point to not include the NRS if you have a priori stated that you were going to?
My first thought is, in many ways, including non-randomized studies introduces some bias to the scope of your review anyway, and we can't really tell the direction. Secondly, I would see it as two very different searches. Okay, so let me just make this out there, and it's a real good question. So if you decided in advance to include non-randomized studies and randomized trials, and your randomized trials all showed a positive effect, and your non-randomized studies all showed a negative effect, and you decided, because you had 17 randomized studies, to exclude your non-randomized studies, you would have a more positive effect than you initially set out to look for, right? But I would also make the counter-argument that your risk of bias is going to be generally less within your randomized trials, so the likelihood of getting closer to the truth, I would argue, is probably true. But I'm sure we can have a long discussion about this. Thanks for the question. Anyway, so yeah, I'd have to think about this a bit more, but my general inkling is I would have less of a problem doing that. I would have way more of a problem of adding non-randomized trials after. Okay, so I'm going to move on. I had a sip of my water. I should be ready to go now. So these are the objectives of the paper that I mentioned that's coming out in the Journal of Clinical Epidemiology. How many EPOC reviews of health systems interventions considered non-randomized studies? First of all. Secondly, how many non-randomized studies were included? And thirdly, is there a connection between the proportion of non-randomized studies found and the review topic? So I have to tell you, this project has been going on for a long time. We did a first draft of it about 6 or 7 years ago that we presented at the Cochrane Colloquium in Australia, and we've continually kept working on it. Finally, we're able to get ourselves in gear to get it published. What we did at this point is we've examined the EPOC reviews published up to March 2010, recorded the study designs searched for, as well as recorded the study designs found. So we're looking for both areas of interest, not only what the authors were looking for, as well as what they decided, what they actually found. I think there was a bit of perception that we were a lot more open with our inclusion criteria, but as I've tried to point out to you today, we're not as clear with it. We're very clear with it, rather. We're not as open with it. We also calculated the proportion of included non-randomized studies for reviews that considered it, and then we categorized EPOC reviews by topic to explore whether there were differences in the proportion of non-randomized studies. We worked very closely with a group in Hamilton who developed the Health Systems Evidence Database, and what we decided was to use their taxonomy to categorize our interventions. We have our own taxonomy, but we decided to use this one for the purpose of this study. We looked at governance arrangements as one possible category, which is political, economic, and administrative authority in the management of health systems, such as regulation. We looked at financial arrangements, user fees, co-payments, etc., as a second category. We looked at delivery arrangements, which is human resources for health and service delivery, lay health workers, nurse substitution, changing the role of pharmacist reviews, and implementation strategies, which is the use of interventions, which are the kind of things I talked to you about earlier, on-screen reminders, audit and feedback, education materials. So those are the 4 categories we used. So at the time, we had 65 published EPOC reviews, and 51 of them considered including non-randomized studies. So the other 14 said, no, we're not including non-randomized studies, we're just looking for RCTs. So of these 51, 5 ended up being empty. Even though they considered non-randomized studies, they still ended up being empty reviews. I'm going to move here. Sorry. There we go. They still ended up being empty reviews. 46 found at least one randomized trial or non-randomized study. 8 of them did not find any non-randomized studies, and 38 of them did. Okay, so again, even though these 46 that found at least one study, 8 of them still didn't find any non-randomized studies and only found RCTs. So of the 5 reviews that did not identify any studies, 3 were in delivery arrangements. One's on social franchising. 2 were in governance arrangements. 1 was on social franchising. 1 was on care homes for adults and looking at different things around the delivery. But we basically found a total of only 5 reviews that did not include any studies at all. We also had a review in the delivery arrangements on smart home technologies, which are electronic technologies that improve care in the health or take care of an emergency situation. Again, there were no reviews on them. And organizational infrastructures for nursing practice, and there was no reviews on that as well. And in terms of governance, interestingly enough, one of the reviews we have that's empty is interventions to improve the proportion of health professionals practicing in rural and underserved areas. I'm sure many of you are aware that's a real problem in our society of getting health professionals out to these rural and underserved areas, and there aren't any reviews that suggest how we might do that, or that have any evidence about how we could best do that. So of our total 65 EPOC reviews, when you break them down into the intervention categories that I mentioned, there's over half that have delivery arrangements interventions, 24% have implementation strategies, and then 11 and 8 have financial and governance respectively. Of the 51 reviews that considered non-randomized trials, I'm going to go flipping back and forth a little bit here, but you can see there isn't a lot of difference between the graphs. Okay? There's a slightly smaller number of delivery arrangements, but it's not really that much different. So even within the whole proportion of our 65 reviews and which category they fall into, when you look at the ones that are considered non-randomized studies, the proportions are roughly the same. Okay, it's actually 53% here, and then 23%, etc. But you know, without memorizing the numbers, I just wanted to give you an idea that the proportions are roughly the same. So breaking it down further into categories, you can see 19 of our delivery interventions considered and found non-randomized studies with a median number of non-randomized studies of 20.5%. Okay. Within the governance category, that's the one category where we actually found a lot of reviews were non-randomized studies. The others are around between 20 and 50%. I think you can appreciate the numbers are relatively small here, so it's a little hard to make any definite conclusions. When you do actually analyze it, we did find significant differences, but again, the numbers are relatively small. So, although there's some variability in terms of which reviews considered and found non-randomized studies, it's proportion among non-randomized studies versus randomized in that case. I think it's really important that I want to bring out a few points around the analysis and some of the practical implications of making the decision. First of all, there's a lot of time, effort, and expertise required of the review team when you make a decision to include non-randomized studies. As I mentioned, they're more difficult to find due to poor indexing of study design characteristics. We had an EPOC register, but there aren't a lot of registers out there that are very comprehensive, including non-randomized studies. Generally, I find it's more difficult, in my experience, to extract the necessary data from non-randomized studies. It's not always as easy to find as it would be in an RCT. The reporting tends not to be as consistent, and it's just a lot more work to be able to find the data that you're actually looking for. Not only just find the study, but within a study to actually find the data. Talking a little bit about risk of bias criteria, can I just get a quick thumbs up how many of you are familiar with the Cochrane risk of bias criteria? Please. I'm getting ones and twos and thumbs and smileys.
Everyone, you can use the small happy face logo to see the list of emoticons you can send through to Al.
Oh, thanks, Catherine.
So we did see a lot of happy faces and thumbs up coming through, Al.
Okay, good. Yeah. All right. Thank you. So one of the challenges with the risk of bias criteria is applying it across different study designs. Now, I mentioned earlier we will consider controlled before and after studies where there have to be a minimum of 2 groups receiving the intervention. The observations have to be done before and after. When you look at the risk of bias criteria for randomized controlled trials, what the approach we decided to take is to apply the same criteria to controlled before and after studies. But what we find, or what we have to do, is then say these studies will never get points or will never be regarded as low risk for allocation concealment or random allocation. Because by definition, they don't do it. Okay, they don't randomly allocate. You just have 4 groups where 2 receive the intervention and 2 do not. So there's no random allocation and there's no allocation concealment. So compared to randomized controlled trials, they're already going to have a high risk of bias because they're not going to get either of the first 2 criteria. So it's a real good question about whether that's the right approach or not. That's the approach we take. What it does is it says these are higher risk of bias studies compared to RCTs, and so we're going to grade them appropriately. The other challenge is that we have totally different criteria for our interrupted time series. Remember that beautiful squiggly graph I showed you earlier on with 3 data points before the intervention and 3 data points after? We have very different criteria for our risk of bias. So if the criteria are different, you can't really compare between study designs. Okay, because what we've done is we have specific different criteria for our interrupted time series, which are not the same as the ones we use for CBAs and RCTs. So if you get, say, interrupted time series, all score low risk of bias and all the criteria are still different. So it makes it more challenging to compare. And you really have to analyze them separately in terms of the risk of bias and the quality assessment, because you can't merge the effects together. Then the next question is, what about on the actual review results? Sorry, can you actually compare the results of the synthesis of an RCT versus the synthesis of non-randomized studies? What if the results are different? This is a study we've done, an EPOC review that was published quite a while ago now, was done looking at reminders for immunization, both patient reminders, electronic, and provider reminders as well, how you remind people that their shots are due, you know, tetanus or polio or whatever the vaccines are for adults and children, and how you actually do that. So this is, interestingly enough, the last time the review was updated was about 3-4 years ago. The authors are working on an update now. They actually described this in the text, but we put it into this nice little graph for you that we thought would help explain it a little bit more. For the randomized control trials, looking at comparisons of patient reminder recalls and provider reminder recalls, the odds ratio was about 3.65, and this is the confidence interval. Okay. However, in the CBA, we only found one study, which is why there's no confidence interval quoted here, and the odds ratio is 1.32. So the odds ratio is less in the CBA than it is in the RCT. But then there's a big part of me that says, so what does that mean? Okay, do you say, well, it's pretty close, or do you say, well, it's really different because it's a CBA, or a CBA, you know, clearly it's more effective because the RCTs all say that, and how do you actually compare this result to this result? Okay, we can graphically look at it, but there's no statistical comparison you can do, and even the comparison, I'm not sure how valid it is. These are quotes right out of the handbook, and they're a little wordier than I normally like to put on my slides out of the Cochrane handbook, but they're both really helpful things to think about. Okay, so we're just going to spend a little bit of time on this, and I might use some of the fancy features here. It is not logical to assume that finding no difference of the results of a non-randomized study synthesis versus an RCT synthesis means that the non-randomized studies are valid. Or that, can you say finding a difference means the non-randomized studies are not valid? So if I just go back a slide again, this is pretty close. It's not quite within the scope here. But, you know, if you were going to try and make, and like I said, it's just outside of the confidence interval, but given that they're close, you can't really then assume the non-randomized study is valid just because the results are close. Just as the same way you can't assume that finding a difference means the non-randomized studies are not valid. So I'm just going to take a second for this, because I think this is a really important point, that you can't base the validity of a non-randomized study on whether the results are close to the results of the RCTs. Furthermore, if multiple factors distinguish randomized trials and non-randomized studies and influence effect size, then observing no difference between the effect size estimated between the two groups can be explained as the consequence of the effect of multiple factors influencing the effect of an intervention in different directions. So if there's multiple reasons that separate, that distinguish, or there's a lot of reasons why the randomized trials and non-randomized trials are different, you don't know if all the factors move the results of the non-randomized study in the same direction. Some may move the results closer to the RCT results, some may move it further away. And you really can't get a sense for that. Because as I mentioned a few times, there's an inherently more bias within the non-randomized studies, and therefore you really can't always tell which direction that bias will move the effect size in. Again, really important point in the handbook in section 13.5.1.2, which is actually a good chapter. I really like it, and I think it's pretty clear in a lot of things. Sorry, the whole handbook is full of good chapters, so I don't need to specify this one. But nonetheless, I think it's something that's really good. So I think I don't know if discussion is the right heading for this slide or thoughts to think about, but it's kind of like you need to weigh out what are the additional resources that you need to consider that are required to include a non-randomized study versus the impact of including a non-randomized study, and how is it going to affect the results. And it's not an easy decision. It's one that should be taken really carefully and thought about a priori. So, conclusion that I would say here, first of all, most EPOC reviews search for non-randomized studies, but the degree of non-randomized studies found varies greatly. And secondly, inclusion of non-randomized study in a review is a decision that should be taken cautiously with consideration of the impact of the conduct of the review and the interpretation of the findings. Here's my contact details, and I'll do my own plug for the Quebec City Colloquium as well. You can feel free to email me after if you have questions that we didn't get a chance to get to today. And Aaron has just popped the link up for the evaluation form, or Catherine, I guess, whatever, has just popped up the link for the evaluation form, and I would encourage you all to do that.
All right, thank you, Al, very much for your discussion today. Can we all send him a round of applause with our emoticons? All right, perfect, everyone. Thanks. We have some time for questions. So as we're waiting for them to come through, I just want to remind everyone to fill out the evaluation. The link has just been sent through the chat room. Al, Suzanne had a question. Are you saying that you need 2 intervention groups and 2 control groups in a controlled before and after, and why?
Okay. Yeah, good question, Suzanne. In order to, it's not so much that you need it, but that's our criteria for including a controlled before-after study within a review. So if we're looking for control before-after to include in our review, we ask for a minimum of 2 intervention and 2 control groups. We just found there were just so many biases when you only had 1 group in each arm that we were finding it was really difficult to actually interpret the results. We used to do that, and we probably changed this about 5-6 years ago, where we actually asked for 2 groups in each. Because as I mentioned before, they're already running the risk of being at high risk of bias because there's no allocation and no allocation concealment and no random allocation. So we've made that decision because we just found they were just fraught with too many errors when they had just 2 groups. I can probably send you a bit more information on it if you just put me an email after. That'd be great.
Okay, thanks, Al. And Angela has a question. Is EPOC developing a specialized risk of bias tool for non-randomized studies? We have a risk of bias tool for interrupted time series. If you go to our website or look at EPOC reviews to include interrupted time series, Angela, you'll actually see that there's very specific criteria. So we don't have a tool for all non-randomized studies because we would base that tool on the type of non-randomized study or the criteria that it met. So it's very different criteria for interrupted time series because these are different designs. In terms of controlled before-afters, we use the same tool that people use for randomized controlled trials, but as I mentioned before, you always get a high-risk rating for allocation concealment and random allocation. So we don't feel you can develop a risk of bias tool for all non-randomized studies at this point. What we can do is say, here's what we're recommending for interrupted time series. Okay, and Catherine, I'll just go on to the next question. All right, it looks like the next question has already been answered. So Angela had a second question. Does the public health group restrict non-randomized study designs?
To be totally honest, Angela, I don't know. But I do know, again, the recommendation in the handbook is that authors should develop their criteria based on components of the design and not just a title of the design. But I'm not sure what the... See, I might have it in my notes here. Just give me 2 seconds. Excuse me for flipping the papers. Yeah, I don't know the answer to that, Angela, but I can follow up and get back to you about it.
Al, I'd just like to point out that earlier Chris had made a point about a possible collaboration with EPOC on a paper, so perhaps you could get in contact with him after the session.
Thank you, Catherine. Yeah, yeah, that'd be great. I'll be in touch with him about that. Angela, I found the answer. At present, currently, what happens is the public health group is asking review authors to provide justification for which designs they will include. Okay, so they're listing basically the same ones that EPOC would include: controlled before-after, interrupted time series, cluster RCTs, non-randomized controlled trials, and RCTs. So they would expect some sort of justification, but the ones they list on their website are the same ones that we will include.
Okay, thank you. Let's send one more round of applause to Al. Thank you so much for attending.